What the study says.
Imagine waking up one day and realizing your hand isn't quite right. You brush it off. Maybe too much texting or you slept on it funny.
Right, something simple.
Exactly. But then it gets worse. You see one specialist, they send you to another, then maybe a neurologist, until, well, one day a diagnosis lands that just changes everything. And this isn't just hypothetical. It's the recent reality for a face many of us know. Grey's Anatomy star Eric Dane. He just shared his battle with Amyotrophic Lateral Sclerosis, ALS.
Yeah, I saw that news.
He's celebrating good days,
Yeah.
even though he's already lost significant function in one arm. He's approaching it one day at a time. He told Fox News Digital, "Today's a good day." So that's a win. It really brings home the impact, doesn't it?
It really does. Welcome back to What the Study Says. I'm Dr. May.
And I'm Dr. Kai. So today we're doing a deep exploration into Eric Dane's journey and also the really complex world of ALS, which you might know as Lou Gehrig's disease.
Our mission here is to help you understand the core concepts, what this neurodegenerative condition actually is, who it affects, the real challenges in getting a diagnosis, and where things stand with treatment and management right now.
Yeah, we want to give you those key insights, not just the what, but really the why it matters. Ground the science in real experiences like Eric Dane's, and also talk about the hopeful steps happening in research.
Absolutely.
So let's start with Eric Dane's experience. It gives such a personal view on ALS. He shared on Good Morning America, his first symptoms were subtle, just weakness in his right hand.
Easy to miss initially.
Totally. He didn't think much of it. Maybe too much texting, he thought. But then, he said it worsened pretty quickly over just a few weeks.
Wow.
And that led him down that path so many ALS patients travel. Multiple specialists, a hand specialist, another one, a neurologist.
Yeah.
Then a second neurologist who basically said, this is way above my pay grade.
Oh, boy.
And that's when the diagnosis came, ALS, just this past April.
And what's really striking, I think, is the speed of the progression he's described already. He mentioned having only one functioning arm now.
Yeah.
His right side, he said, has completely stopped working. It's devastating. And he shared this incredibly sobering thought, didn't he, about his left hand maybe going in just a few months?
He did. He said a few more months maybe. It's just a stark, immediate picture of how relentlessly this disease can take away physical abilities.
Yeah, it really is.
And yet, what's kind of amazing, given everything he's facing, is his perspective, his resilience.
Right. Despite these huge physical changes, his outlook seems remarkably positive.
He told Fox News Digital, "Today I'm doing great. I'm approaching this thing one day at a time, and today's a good day." So that's a win, that attitude.
It's powerful, and he's not just thinking positively, he's acting on it, staying committed to his work.
Yeah, he said he's going to ride this till the wheels fall off. He feels like working on his new show, Countdown, keeps him sharp and moving forward, which he said is super important right now.
And you can see how that openness resonates. Online, people are responding with so much empathy, sharing well wishes.
Lots of mentions of support organizations, too, like Steve Gleason's.
Exactly, like no white flags.
Yeah.
It just shows how a public figure sharing their struggle can really boost awareness and galvanize support.
It really does. So let's pivot a bit to the medical side. To really grasp what Eric Dane and others are facing, we need to understand what ALS actually is.
Okay, so ALS, amyotrophic lateral sclerosis. It's classified as an idiopathic neurodegenerative disease. Idiopathic meaning, well, we don't know the exact cause.
Right. Unknown cause.
And it specifically targets the human motor system. It leads to progressive muscle weakness, disability, and eventually it is fatal.
The name itself is descriptive, isn't it?
Oh.
Amyotrophic lateral sclerosis.
It is. Amyotrophic refers to muscle atrophy, muscle wasting, and lateral sclerosis. That describes the hardening, the scarring of specific nerve pathways in the spinal cord, the lateral corticospinal tracts. And what's really characteristic of ALS is that it hits both upper motor neurons, the ones starting in the brain, controlling things like muscle tone and reflexes, and lower motor neurons, the ones going from the spinal cord out to the muscles, responsible for direct movement.
So it's attacking the system from both ends, essentially.
Pretty much. And that dual attack is why you see this relentless progression. No real remissions, no flare-ups, and quiet periods. Symptoms usually start in one area, like an arm.
Like with Eric Dane's hand.
Exactly. And then it spreads to the other arm, maybe, then the legs, systematically moving through the body region.
Now, who gets ALS? Are there patterns? You mentioned Lou Gehrig's disease earlier.
Right. So looking at the epidemiology, ALS is found worldwide. In the U.S., roughly 7,000 new cases pop up each year.
Okay.
There's a slight leaning towards men, about 1.3 to 1.5 men for every woman diagnosed, though that difference kind of levels out after each 70 or so.
And age itself is a big factor.
Oh, definitely. Age is a major risk factor. The peak time for diagnosis is typically between 60 and 75 years old. It gets less common after 80.
Are there different types, maybe affecting age of onset?
Yeah, there's sporadic ALS, which is the vast majority of cases, maybe 90%. That tends to peak around age 58 to 63. Then there's familial ALS, the inherited form, about 10% of cases. That often shows up earlier, maybe 47 to 52 years old.
And lifetime risk. You hear numbers thrown around.
The lifetime risk is estimated around 1 in 350 for men and 1 in 400 for women. So while it's considered a rare disease overall, that's still significant.
It is. And survival rates are often mentioned, and they sound quite grim. What's the reality there?
Yeah, the statistics can be stark. About half of patients, 50%, die within 30 months of their symptoms starting.
That's fast.
It is, but it's not the same for everyone. Around 20% of patients survive between 5 and 10 years, and a smaller group lives even longer.
Are there factors that predict longer survival?
There seem to be. Things like being younger when symptoms start, having the disease begin in a limb, an arm or leg, not the mouth or throat area, which we call bulbar onset.
Okay.
And interestingly, a longer time between symptom onset and diagnosis.
Wait, a longer diagnostic delay means better survival? That sounds backward.
That does, doesn't it? But it probably doesn't mean the delay itself is good. It likely means that people with slower progressing forms of ALS naturally take longer to get diagnosed because the symptoms are less aggressive early on.
Ah, okay. That makes more sense. It reflects the disease course, not the delay being beneficial.
Exactly.
So that brings us to the huge question. Why? Why does this happen? What actually causes ALS?
That's still the multi-million-dollar question, really. The exact cause, or etiology, is largely unknown. That's a massive hurdle for finding a cure.
There must be theories, right? Research directions.
Oh, absolutely. There are several proposed mechanisms being heavily researched. One involves problems with how cells process RNA and handle proteins, leading to clumps or aggregates. You might hear about genes like TDP43 and FUS in this context.
Like cellular gunk building up.
Kind of, yeah. Cellular miscommunications or clogs. Other ideas involve excitotoxicity, basically, neurons getting overstimulated and damaged.
Too much activity.
Exactly. Then there's mitochondrial dysfunction, the cell's power plants not working right, and also inflammatory responses within the nervous system that actually end up harming the motor neurons.
That sounds less like one single trigger and more like a complex cascade of things going wrong.
That's a great way to put it. It's likely a complex puzzle. Different cellular pathways might go awry, leading to the same outcome. Motor neuron death. This complexity makes finding a single magic bullet cure incredibly difficult.
Okay, so a complicated picture inside the cells. What about external risk factors, things we're exposed to?
Well, the only really solid established risk factors are age, which we talked about, and have a family history for that familial 10%.
Right.
But evidence is building for cigarette smoking, and that seems to be an emerging risk factor.
Okay, smoking. What else?
There's weaker or more conflicting data on other things. Military service, especially for Gulf War veterans, has been looked at. Certain jobs like agricultural or factory work, exposure to pesticides, welding fumes, heavy metals.
Lots of possibilities, but nothing definite.
Pretty much. No single environmental toxin or virus has been definitively linked to all cases worldwide. It's likely an interaction between genetic susceptibility and environmental factors, but we're still figuring out the specifics.
You mentioned something interesting earlier, too, that it's not just the neurons themselves. Even the support cells are involved.
That's right. Non-neuronal cells like glial cells, astrocytes, microglia, these are normally the brain and spinal cord's support crew. But animal models suggest they actually play a role in the disease process, contributing to the damage and progression.
So the whole neighborhood around the motor neurons is kind of going bad.
In a manner of speaking, yes. It points to a much broader cellular problem than just the motor neurons dying in isolation.
Which probably makes diagnoses even harder. Let's talk about that diagnostic journey. Eric Dane's story highlighted how tricky it can be.
Absolutely crucial point. And yes, it's a major source of frustration. There's no single blood test or scan that says, yes, this is ALS. Not yet, anyway.
So how do doctors diagnose it then?
It relies heavily on clinical judgment, putting together the pieces. observing those signs of both upper motor neuron damage like stiffness, spasticity, exaggerated reflexes, and lower motor neuron damage like weakness, muscle wasting, twitching.
Both types of signs have to be there.
Yes, typically in the same body region. And then, crucially, doctors need to see evidence that the disease is progressing over time, getting worse.
I can just imagine how anxious that waiting and watching period must be. Are there specific criteria used?
There are. Clinicians often use what's called the L-Escorial criteria. More recently, the Gold Coast criteria were developed to try and simplify things and potentially speed up diagnosis.
But even with criteria, there's still that delay.
Often, yes. The median time from symptom onset to a confirmed diagnosis is around 14 months.
Over a year? Wow.
Yeah. And during that time, patients might get incorrect diagnoses, maybe even treatments that don't help or could potentially harm, and they miss out on starting the right kind of support, both medical and psychosocial. It's a really difficult period of uncertainty.
So if there's no single test, what tools are used in the workup?
Electrodiagnostic studies are key, especially electromyography, EMG.
What does the EMG show?
It looks at the electrical activity in the muscles. In ALS, it can show signs of nerves dying off denervation, and also signs that the remaining nerves are trying to compensate by branching out reinnervation. But ultimately, the denervation wins out.
And those muscle twitches people sometimes see, fasciculations.
Yes, EMG is very good at picking those up. Fasciculations are common in ALS, though they can occur in other conditions too. But seeing them widely, especially in the tongue muscle, is quite suggestive of ALS during an EMG.
What about brain scans, like MRI? Do they show ALS?
Not directly, usually. The main role of MRI is actually to rule out other conditions that could mimic ALS. Things like spinal cord compression, tumors, stroke, multiple sclerosis.
So it helps exclude mimics.
Exactly. Now, advanced MRI techniques are being researched as potential biomarkers to track disease progression. But for routine diagnosis, a standard MRI in ALS is often normal.
That point about mimics seems really important. Why is ruling them out so critical?
Because some conditions that look like ALS initially are actually treatable. That's the most crucial reason.
Like what? Give us an example.
A key one is multifocal motor neuropathy, MMN. It causes asymmetric weakness, mostly lower motor neuron signs, often in the hands or arms. But crucially, sensation is usually normal, and specific nerve conduction tests show something called conduction block.
Okay, different test results.
Right. And the big difference. MMN often responds well to treatment with intravenous immunoglobulin, IVA. So making that distinction is vital. You don't want to miss a treatable condition.
Absolutely not. What other mimics are common?
Things like severe cervical radiculomyelopathy, basically pinched nerves in the neck, causing both upper and lower motor neuron signs, or even benign fasciculation syndrome, where people have lots of twitching but no actual weakness or muscle wasting. It's annoying, but not progressive like ALS.
Okay, so that must be reassuring for some people who just have twitching.
It can be, yes, though getting it properly checked is important. And then there are neuromuscular junction disorders like myasthenia gravis or Lambert-Eaton syndrome. Different mechanisms, different tests, different treatments. So the diagnostic process is really about careful clinical exam, EMG, imaging, and sometimes other tests to exclude everything else.
Okay, let's shift to living with ALS. We know it attacks the motor system, like with Eric Dane's arm. But does it stop there, or are there other aspects?
That's a really important area. While ALS is defined by motor neuron degeneration, non-motor symptoms are actually pretty common. They can affect up to 50% of patients, sometimes even early on.
Like what kind of non-motor symptoms?
Cognitive changes are significant. Problems with executive functions planning, decision-making, cognitive flexibility, language difficulties, sometimes personality changes.
Really? Personality changes?
Yes.
Yeah.
And in some cases, up to maybe 15%, the cognitive impairment is severe enough to meet criteria for frontotemporal dementia, FTD. Having both ALS and FTD often predicts a faster disease course.
How might those cognitive changes show up?
It could be things like apathy, losing motivation, or disinhibition, saying or doing inappropriate things. Sometimes changes in eating behavior, like developing a strong sweet tooth. It adds another layer of complexity for patients and families.
I've also heard about something called pseudobulbar effect. What's that?
Ah, yes, PBA. That's characterized by emotional ability, uncontrollable, exaggerated episodes of laughing or crying, sometimes yawning.
Uncontrolled.
Yeah, and often it doesn't match how the person actually feels inside. It can be triggered by very small things and be quite socially distressing.
Wow. What else beyond cognitive and emotional changes?
Fatigue is huge. Around 90% of patients report significant fatigue. Pain is also common, from muscle cramps, stiffness, or immobility. Sleep problems, constipation due to reduced mobility and muscle function, and celluria, excessive drooling because of difficulty managing saliva. These are all frequent challenges.
It really sounds like a disease that affects almost every aspect of life. So, given this complexity, how is it managed? What does care look like?
Well, on the medication front, unfortunately, options are still limited. Riluzole is the main drug shown to have some effect on survival, maybe extending it by, on average, 3 to 6 months. There are a couple of newer drugs approved in some places, but their impact is still being fully evaluated.
So medication isn't the main pillar of care.
Not entirely, no. The absolute cornerstone of good ALS management is comprehensive, multidisciplinary care.
Meaning a whole team.
Exactly. A dedicated team working together, neurologists, of course, but also physical therapists, occupational therapists, speech-language pathologists, respiratory specialists, dietitians, social workers, palliative care specialists, all focused on the patient's needs.
And does that team approach actually make a difference in outcomes?
Oh, absolutely. Studies have shown that patients receiving care in specialized multidisciplinary ALS clinics have better survival rates, like a 45% lower risk of death at 5 years compared to standard care.
Wow, that's a huge difference.
It is, and it also significantly improves quality of life. It's about proactive, coordinated management of all the different symptoms and challenges as they arise.
What are some key areas that team focuses on?
Respiratory management is critical. Respiratory failure is the leading cause of death in ALS. So regular monitoring of lung function is vital tests like vital capacity, MIP, SNIP, usually done every 3 months.
And if breathing starts to weaken?
Non-invasive positive pressure ventilation, or NPTV, often a mask worn at night, like BiPAP, is really important. It improves quality of life and survival, especially when breathing gets difficult during sleep.
What about more invasive ventilation, like a tracheostomy?
Invasive mechanical ventilation via a tracheostomy can prolong life significantly, but it comes with enormous challenges. It means total dependence on a machine, loss of voice, intensive care needs. It's often described as involving a profound loss of quality of life, and it's not commonly chosen in many places due to the practical, financial, and emotional burden.
That sounds incredibly difficult. What about nutrition? You mentioned swallowing problems.
Yes, nutritional support is another key pillar. Malnutrition is common and negatively impacts prognosis. This happens because of dysphagia, difficulty swallowing, but also because ALS can cause a hypermetabolic state where the body just burns through calories faster.
So feeding tubes are often necessary.
Yes, a percutaneous gastrostomy tube, or PEG tube, placed directly into the stomach is often recommended. Ideally, it's offered relatively early, before breathing function declines too much, to ensure patients get enough calories and fluids safely.
And then managing all the other symptoms.
Right. Symptomatic therapies are crucial for quality of life. Medications for muscle cramps and spasticity, like baclofen or tizanidine, treatments for excessive saliva. There's even a specific medication for pseudobulbar effect, that laughing crying issue, managing pain, fatigue, constipation. It's all part of that comprehensive care plan.
With such limited disease-modifying options, I imagine patients look elsewhere too. What about alternative or unproven treatments?
That's very common and completely understandable given the diagnosis. People are desperate for hope, but it's an area where patients really need to be cautious.
Why cautious?
Because many alternative or off-label treatments you might see advertise things like certain stem cell therapies or supplements like lithium carbonate in the past often have little to no good scientific evidence behind them for ALS.
And they could even be harmful.
Unfortunately, yes. Some things tried in clinical trials have actually been shown to potentially worsen muscle weakness or negatively impact survival. It's really important to discuss any potential treatment, especially unproven ones, with the neurology team.
Is there a way for patients to get reliable information on these?
There's a useful initiative called ALS Untangled. It's basically a group of clinicians and researchers who systematically review alternative and off-label therapies that patients ask about. They publish reports looking at the potential mechanism, the evidence, or lack thereof, the risks, and the costs. It helps provide a more objective assessment.
That sounds like a valuable resource. Okay, let's circle back as we wrap up. Eric Dane sharing his story. What's the wider impact?
I think it's significant. When a public figure like him opens up about a disease like ALS, it dramatically increases awareness and understanding way beyond the medical community.
Puts a human face on it.
Exactly. It makes the statistics and the clinical descriptions real and relatable. That fosters empathy, reduces stigma, and can really inspire people to support research for patient advocacy groups.
And his attitude, his decision to keep working, that ride this till the wheels fall off mentality.
It sends a powerful message about resilience, doesn't it? About finding purpose and staying engaged, even when facing something so incredibly challenging. It reminds us that living fully is about more than just physical function.
Absolutely. It's inspiring not just for others with ALS, but really for anyone facing adversity.
I agree. That capacity to find meaning and keep contributing, it's profound.
So, as we've explored today, ALS is, well, it's a formidable opponent. A complex neurodegenerative disease still without a cure, but understanding its complexities from how it starts to how it affects the whole person really highlights the challenges and also the critical need for ongoing research and that compassionate team-based care.
Definitely. Eric Dane's journey really underscores the insidious nature of ALS and that often long, frustrating road to diagnosis. But his story, combined with all the dedicated work happening in labs and clinics, it does offer a real beacon of hope. Hope for better diagnostic tools, more effective therapies, and ultimately improved quality of life for everyone affected by ALS.
So what does this all mean for you listening? Maybe it's a reminder of just how complex our bodies are and the ongoing quest to understand and overcome diseases like ALS. Perhaps it makes you think about resilience or the importance of supporting medical research, or maybe just appreciating the good days in your own life, like Eric Dane is trying to do.
Indeed, neuroscience is moving incredibly fast. New insights into genetics, biomarkers, cell biology, they're emerging all the time. The big question is, how fast can we translate those scientific leaps into real, tangible benefits for patients? And what role can awareness, boosted by people like Eric Dane sharing their stories, play in speeding up that translation? It's a critical question for all of us.
If you found this deep dive helpful and informative, please do subscribe to What the Study Says. And maybe share this exploration with friends, family, or anyone you think might benefit from understanding more about ALS.